I also just want to praise Dr. Alex DaSilva. I've gotten to know him over the years. As you'll hear, really, really beautiful, elegant work looking at mechanisms underlying some of these neuromodulation effects and applying it to pain. And so I think this is especially relevant, and Dr. Silva will talk about a number of different populations. But if we think about our older adults who often have chronic pain and we know are especially sensitive to opioids and other medication effects, I think this is a really, really promising area. And I got to say, this guy is one of the best people I know. So it's a pleasure to have you here. And thanks for being here.
You talk with my mother, no? So thank you very much for the invitation. It's so great to speak and learn. So many people that I read the papers and learn a little bit more of neuromodulation. I'll start with that. I'm a dentist, so I'm pretty good at provoking pain. And when start to see patients with pain, I wanted to have something more objective. Pain is very subjective, and it's very hard for the patient to provide that information to see if our treatments are doing well or not. So when I tried to do my doctorate, I really wanted to use the brain as a target and become more objective, how we process pain and everything related to pain, not only the intensity of the pain, but emotion, but the cognition, all the process related to that. And so I started to work, and I was with mentors at Martino Center. So I started to go into the very deep into the neuroimaging side. And I started to work with colleagues that were starting neuromodulation. So for me, it was kind of the neuroimaging part going to the neuromodulation part to start to modulate the brain, and then going back with this, what I was start to learn and develop technologies or ideas that going back to the clinic. So basically, it's really my training, including psychiatry department back in Boston. So it's try to understand how we process pain in our brains, especially trigeminal pain, including migraine, and how we can modulate that. And then going back, it's not so much if it works or not, it's like how in the human brain, how that starts to make sense, and for us to better understand, provide better options to patients in treatment. And Ben asked me to start to talk a little bit about aging. And so I start to always to add some of the aging concepts in pain. And some of the data, I've just asked my team to start to look, and so to provide some information to the audience here. And it was very interesting because we start to learn so much about aging and pain. So these are the funding for, there's no disclosure that these are all the technologies that I will show here. They belong to the University of Michigan, developed by some of them by our team. So these are the grants that we lead in TMD, migraine, fibromyalgia, and also internal with the BOLD initiative. And also I'm collaborating with the R35, which PI is Ben. So it's a wonderful opportunity to also at least have burgers and discussions and put science into that. So this collaboration is very productive in many ways. So why pain? Pain affects 100 million adults in the United States. So this is a huge number. And we always think, oh no, this is only mild pain. No, it's not. It's like 1/3 of them moderate, 1/3 of them severe, and half of those patients have a daily pain. So imagine how that impacts their lives. And we also think that's just adults, but that's not the case. You also have the children, pediatric population, the 46% of them have some kind of the pain, visceral pain, for example, headaches. And you also look into the elder population, 50 to 80% of patients in the nursing home have some kind of pain. So headaches, back pain, so several kinds of disorders. So pain is across our lifespan. And the interesting thing is that it's not only because pain is impact your life as you do. So some kinds of chronic pain also going to impact your brain for other disorders as you age. One good example, patients with migraine has a high incidence of Parkinson's. And we can talk more, have a data in dopamine, we can talk in questions and answers. But for example, if you have a chronic migraine with a 15 daily attack, so day of attacks per month, you have even a high incidence of Parkinson in later life. So it's not only the impact of the chronic pain disorder right now, it's like what might change our brain for the future. And so in many cases. So how about the brain and what wanted to explore with the across our lifespan? And I put the man and woman because sex, even in the aging, has a huge impact, especially the more opioid system. So what we're going to talk today is really like the age and also sex in the brain, the effect, especially the more opioid system. Why the more opioid system? Arguably, it's one of the most important analgesic that modulates, endorphins that modulates pain, reward, and also cognition too, and emotion. So several things are related to that. So we're going to talk about health patients, but also with pain, chronic pain, how that starts to affect our brains, how the receptor system. So in humans, we studied with positive emission tomography, and how neuromodulation start to change that, and how we can target, especially the motor cortex, and start to change the more opioid receptor availability in our brains, especially with high definition. And some of our ongoing projects that we develop technology to bring back from the neuroimage, especially to the clinic. So our aging brains. The interesting thing is that if you look in this study that was recently published, the opioid receptors in our brains, they change with across our time. So we have like an increase of opioid receptors, especially in temporal frontal areas, in several areas in our brains as we age. In part because there is less of opioids peptides being released in, for example, the frontal temporal area and several areas that you see there, caudate, temporal pole, and this in health subjects. There's only 3 areas, or not only 3, but 3 that became significant in this study, is that decrease opioid receptor availability in our brains. It's in the amygdala, the limbic system, the thalamus, that is right related to several things, including pain processing, and the nucleus accumbens that reward and the aversive system in our brains. You can see from there that is a huge change in binding from females and males. So females, usually, we do have increase that at the very beginning, and then males in the 30s, 40s start to increase really sharply. So this for you to start to understand that aging also changes a system that is very important for pain modulation and also reward. So not only that, males and females change across time with chronic pain incidence. So many of the chronic pain disorders affect much more women than men. And that's also related to some of the hormones we're going to talk to. So boys and girls until puberty, they are the same. They suffer with, especially migraine, the same level. But when you start to have a puberty, so you start to differentiate. You can see in the first peak here, 13 years old, girls, they start to have much more headache attacks. And then you have, compared to boys and males. And then you have a second peak there, that is the postmenopause. And then so you have the decrease with time. But pay attention, because migraine is not only the headache. You have the nausea, vomit, cognition, emotion, photophobia, phonophobia. There are several elements that also affect patients with pain. And as I mentioned, testosterone and estrogen, they actually change a lot and is responsible for these functional changes in the brain. Testosterone is more analgesic, and actually estrogen is actually facilitates some of the pain and the suffers that women have. So, and this is not only about something that's only functional, even structural. So you can start to see boys and girls, then males and females start to change. Many of the changes, neuroplasticity that you see in those patients, especially in the limbic system, that again related to emotion, cognition, in many ways. So, what happens in your brains when you have a migraine attack? Basically, your brain starts to release more opioid receptors, more opioid peptides, and float in the system. So you have less of opioid receptors available, especially in the limbic system. So what happens? Even if you prescribe opiates to these patients, they're not going to be so effective, because a lot of those receptors they're going to be taken by the more own endogenous system, so which is the opioid peptides, endorphins, for example, beta endorphins, for example. And this is mostly a lot in the amygdala. If you compare patients that are chronic migraineurs, more than 15 attacks day per month, comparing to episodic, less than 50 days. So you have much more dysfunction in the amygdala. So you can see that the attacks during the scan is a pain in the neck to scale those studies, because the patients, many of them are during the attack, especially with chronic migraineurs, we have to control for medication. There are several things that we have to control with those patients for the post-remission tomography. So, and this is highly correlated with the clinic. The more sensitive they are, what you call allodynia. So we apply a stimulus that's not supposed to be painful, but become painful. So like patients during the migraine attack, they brush their hair. So that's painful for them, but it's not supposed to. It's because in the central nervous system become very sensitive to those. And the more of the sensitive, we call it, in this case, thermal allodynia that we do inside of the scanner, the PET scanner, so it is related to more of dysfunction in those patients. And the more of the area intensity, the severity of the attack, not only the intensity, but also together with the area, so the higher is the dysfunction in the amygdala, especially the right side. And we can talk more and more of that. So when I asked my team, hey, look at the age, let's help, let's make Ben and the crowd really happy with that. So this is data that we just look. So remember, with age, there is an increase in more opioid receptors availability in the patients. So this is the health controls in our studies. And look at the migraine. So much less than the health controls, especially in the mid-temporal lobes. And you can see here, so with this preliminary data that we just analyzed for this event, so how the migraine, so the health controls with age, so we start to increase the number of opioid receptors available, but the migraineurs is different. One, because there's more release of opioid peptides and downregulation of those receptors because of the stimulation. So can you reverse that using brain stimulation? And the way that we did that is to, that's cool, no? So it's like, I wanted to, okay, let's, how can we do that? Which area and how? So neurosurgeons, in very severe case of chronic pain, they stimulate the motor cortex, not the sensory cortex. And the electrodes there, So there is also current that is from posterior to anterior part in some of the studies. So in the homuncular area representation for our body is upside down, and is larger. It's quite large for the face and head, and here you have for the hands. And so you can see the face where neurosurgeon put the electrodes for patients with facial pain. So what we did, we create a high definition TDCS that you have anode and cathode with the current going in the same direction from posterior to anterior part of the brain, and only in that case in the caudal part of the motor cortex. Of course, you know who is here, Maron Bixson. Everyone has his head. So we did 10 sessions with 2 million pairs total for 20 minutes. And then we had MRI and PET before, and MRI PET after, the week after. And then we follow up for 1 month, 2 months in those patients. The result here actually were very I was very hopeful with that, because in the first month, what we got is that following the International Headache Society guidelines for clinical trials in migraine, moderate to severe headache attacks, we had a significant effect, responder rate more than 50%, moderate to severe pain, headache probability for the month, and also rescue medication. Actually, it was excellent. Well, we had a really good result, and we had a really good result with that. But what I was really excited about is what happened to the opioid system. And so these health controls that we had as an example of where for all these regions, the opioid system, the opioid receptor availability is. And here is the active, which is in blue, and sham in red. In many areas, especially in the limbic system, we increase the availability of the opioid receptors in parahippocampal gyrus, temporal polar, hypothalamus, amygdala, and we also had in the paraductal gray, look at the direction, increase the opioid receptor availability in many of these regions. One important thing, you want to see that with patients with more than 3 attacks per month, not less than 3 attacks per month. Maybe because this is a kind of a floor effect. So in those patients, it's hard. We have 1 attack per month, and you're like, what happened the next month? So, so in our clinical trials, we really look into the patients with more than 3 attacks per month. So I can talk, I can give some answers related to MRI, but one thing that we also were able to reverse or to bring to the level of health controls in the migraine patients is that bold signal variation is a variability of the signal that in the past we just throw it away. So you can see that we decrease to the level of health control, especially in the ascending pathway, spinal trigeminal nucleus, thalamus, and all the way to also other regions. And in the descending inhibitory system, so we had actually, which in migraneurs are kind of low variability, we increase the bold signal variability in those patients, really bring closer to the health controls. So basically, the areas that you usually see changes, not only in the opioid system, but also in the MRI system in our studies, are many of them relate not only to the sensory system, pain modulation, cognitive, emotional. So you see here many colleagues talking about them, but also in aversive and reward pain behavior. The areas that we are really working on, it's also outside the brain. One area that I'm looking at is the meninges. Why? the brain processes the pain, but the sensory nerves actually come from the meninges. It's where, especially around the middle meningeal artery, for example, is there where the pain inputs ascend and go to the central nervous system. So the more pain we see in the middle meningeal artery, we are working with the Martino Center on that with our data in our team. So less of opioid receptors we have in the middle meningeal artery. And interesting enough, we look at, well, right below the stimulation, what happens to the meninges. Interesting enough, the effect of the TDCS is not only, doesn't happen in the direct opioid receptors in the meninges, but in the contralateral side. So the effect is central, not peripheral. So that's something that we got very excited about. We also control for the area that we look at the pain in the patient, because we are very specific in which homuncular area we are applying. We need to control for where we are changing the pain. If it's only homuncular area for the head, so we look at the head. If you only for the full body, so we look at the changes in pain intensity across the entire body. So we have to be close to that. With another thing that we are doing, and that's at the very end, is actually with technologies that we can bring the imaging to the clinic. In this case, clinical augmented reality. So we do optical imaging. So we collect the data, use AI to tell us if it's pain or no pain. But in this case, it's just navigation. This is a postdoc of mine, so he does have a brain. It's a template in real time. So you go with augmented reality and see brain activation. So we wanted to step by step bring that information to the clinic. And look at this. This is a patient, a group of patients with the dental pain. And so we can see that the AI tell us if there is a pain and if it's the right or left side. This is a very controlled study. So right side, look at the activation of this group here in the caudal part of homuncular area in the frontal cortex. So we are trying to bring AI and neuroimaging and play with that. So with that, I open to questions, but the idea is to really understand the opioid system, and there's technology, but start to learn a little bit more aging and sex, how that really modulates the way that you suffer with chronic pain. This is my team. We have a new postdoc position available. Let me know if you're interested, and thank you. All right, questions? Okay. Yes.
Great. So you're selecting different areas of the motor cortex based on it's the arm, head, back, etc. Are you adjusting the intensity at all? Because some of the depth of those areas are going to vary. Given that, for example, if you're going to try to get the lower back or the leg area, that's going to be deeper in the sulcus.
That's a good question. We are not change the intensity. Okay, so you're asking if you because we target pain different areas in the homuncular area, and how that perhaps intensity we could change to be more effective. So that's a good question. For now, interesting enough, even if you do many of the studies, we do unilateral to actually compare one side to the other. We have one new grant from NIH that do both sides. But this is not, even if it's unilateral, it tends to change the pain to the other regions. So, for example, we did it with TMD, chronic TMD patients. And both these patients are usually bilateral pain, and we only stimulate one side of the motor cortex. The 5 daily sessions, we saw a huge change in the contralateral side intensity and the area of the pain, not in the ipsilateral area and not in the full brain. But then with time, I see the changes also in bilateral pain, the entire head. So it's a kind of a continuum with the system. It's not so, at the very beginning, you start to modulate the contralateral much more than the other sides. It's amazing. And but you have to work with both sides to better understand it too.
Well, thank you so much. We're gonna head into a break, so we'll reconvene right about.